Good afternoon, everyone. Thank you so much for joining us today for our current episode of Breeding is Living. We have a very special guest with us today, Dr. Lloyd DelMundo, who I would like to introduce you all to. Say hello, Dr. DelMundo.
Hi, how are you doing? Thank you for having me.
Oh my gosh. Tell me where you're from.
I'm actually from Las Vegas. Born and raised out here in Vegas. I did high school till here. Went to college in LA at UCLA. And then I did my medical school at Turo and my training here in Las Vegas as well. So I'm as local as possible.
Oh my gosh, you did your training at Turo?
Yeah.
That's awesome. Actually,
Yes.
you know, Provost Shelley Berkeley is on our board. It's funny how the little circle in Las Vegas comes around, right?
I know. It seems so big, the city it's growing, but the circle stays small. A lot of them.
It does. I love that you're from here. That's awesome. Now, tell me what medical system you're in right now.
I'm working with Valley Health Hospital. I'm also working with Turo. So I'm still staying with the same community that I grew up with.
Well, look, you know what? I feel bad in saying this, but you're already way more interesting to me than you were like 5 minutes ago. How funny is that? Like Valley Health Systems in Turo. That's awesome. You know, the Turo students actually just did our Scale the Strat event, and they did a great job. Actually, I think one of them won his age category in terms of time.
Oh, that's awesome.
That is awesome. I love that we all can work together. So I got a call from Morgan, who I'm going to bet runs the show over there, right?
Oh, of course. Morgan's the boss. I just do what she tells me to do. That's it. That's all I do over here.
I could tell she has her act together, and I love that. I got a call from her, and she started to say to me, hey, well, we're doing this thing in breathing. And then I got overwhelmed with excitement, and then I shut down a little. So I would love for you to tell me what is going on that you guys have been focusing on recently.
So we've been trying to enhance our lung cancer screening programs and our lung cancer programs here at Valley Hospital. That's been a goal of ours for a while. Morgan's helped out tremendously, and the administration here has been very supportive of what we're trying to do. So what we're trying to do is get earlier staging for cancer diagnosis. A lot of the people that come into Las Vegas or come to our office are already late stage, meaning stage 3 or 4, which basically just means that the tumor has either spread outside of the lung or it's spread to the lymph nodes. And the therapy for that is going to be different depending on the type of cancer you get. Mm-hmm. So here at Valley, we just invested in an ION, robotic bronchoscopy, which is basically we're using robot controlled arms to control the scope so we can get farther down into the lungs and we can get smaller tumors than we could before, with much more accuracy than before as well. And this allows us to hopefully stage cancer earlier, because if we get the cancer in stage 1 or stage 2, the survivability of these people are like they didn't have cancer to begin with, right. Depending on the type. And so that's been our goal, trying to get these earlier stages so that we can prolong people's life and they can have lived past their lung cancer. Yeah. So that's been the focus. We've got this robot. It's pretty awesome. It allows us to get places that I've never thought we'd ever get to. And it's a lot safer than it was before with the other biopsies. You know, the complications and the risks are a lot less than when you do it with maybe the radiologist, or, you know, nobody wants to go to surgery right away. And so it actually saves them from doing that. And that's the goal. The goal is to get to these people a lot sooner.
No kidding, right?
Yeah.
What we've said all along for any cancer, this is true of any cancer, is early detection. Just let's find it as early as possible. So really, then let's back up one step, if you don't mind me clarifying. The first step then is to get screened, or will this machinery also do the screening?
Oh, that's an excellent question. Actually, the first step is to get screened.
Okay.
You have to get through, go through the screening criteria that they just put out. They just put out a new criteria now, which allows for more people to get screened than before.
Mhm.
So that's the goal. And a lot of these people, these are incidental findings that
Yeah.
they didn't come in with any symptoms. Stage 1, stage 2 lung cancer doesn't really give you any problems. People are not really short of breath. They're not suffering from weight loss yet. They haven't lost their appetite. They haven't had those types of symptoms. No one's coughing up blood. By the time you have those symptoms, the tumor's either grown big enough to that we can see it without something like the robot, or it's too late to do anything but chemotherapy and radiation. So the screening is very important, and it's very important for your, the primary care physicians as well as the pulmonologists to make sure they stay on top of those types of things, because that's what will get us into the system, and then we can move forward from there.
Wow. So screening is something that should be happening how often after a certain age? So let me start there just to make sure I'm on the right path here.
So screening usually used to be 55 to 70. Used to screen for people that had 20-pack year history of smoking minimum, and they did it yearly. So you can follow up on scans like that. Nowadays, they also have recommendations for following up the sizes of the tumors, or not even tumors, like really nodules, right? Tumor is, or a mass is really greater than 3 centimeters. So anything smaller than that's technically a pulmonary nodule. And they have different guidelines for not only screening the nodules as well as following them that you have to do for a minimum of 2 years, depending if it's solid or if it's not solid. Like if it's a not solid lesion, actually, or something that they call like ground glass, those take up to 5 years to follow once you see them. So yeah, getting the screening is very, very important. They change the guidelines every so often to include more people so that we can catch these incidental nodules a lot sooner than we did before.
Right. So now the biometric machine, tell me the name of it again.
It's called Ion. So it's Ion. It's intuitive. It's the same people that made Intuitive made the robot for general surgeons in the beginning, where you can do like taking out the gallbladder and things like that, repairing hernias, those types of procedures. And then they moved more to a pulmonary platform so that we have better access to these nodules that seem to be big. I mean, lung cancer is the biggest, so it's a very good field for them also to invest in as well.
Right, absolutely. Okay, so now you know what I'm picturing literally a robot with 2 hands.
Oh yeah.
Tell me a little more about the actual.
So it's funny because that's what I pictured too when I first heard of it, but it's really not. It's really you have it's pretty cool. It's like I'm looking at you at this computer screen here, but then the screen has trackballs on it, and then the actual robotic arm is the bronchoscope itself. Okay. And the bronchoscope goes through the breathing tube, and then you kind of have to line everything up so that your virtual image and then the real person image are the same. And then from there, it guides you, because what you do is before you actually go into the procedure, the actual procedure itself, you have to take a CT scan, obviously. And that CT scan gets uploaded to the computer. The computer generates this 3-dimensional image where you can find the nodule. And then once you can find the nodule on the 3D image, it guides you. It's like really taking a map. You're just following the map down. And of course, there's, issues that happen along the way and things like that, that it adapts as you do the procedure. It's unbelievable technology.
So it's like your smartphone, but smarter.
Oh yeah. It's like Apple, it's like Google Maps or something like that, where they guide you, So it's, yeah.
So what happens, like during the procedure, are you awake?
Oh, okay.
After the procedure, how long does it take to recover? I mean, like, tell me if you can, like, do you twilight people, which I find out means you're groggy, but you're not fully asleep, or what is it? Like, what do I expect?
Yeah, so when you start off, you get put to sleep. Anesthesia will put you to sleep. Okay. From there, they put the breathing tube in to, help make sure that you're getting properly ventilated, and we go through there. The procedure itself only takes about 30 to 45 minutes. You're sleeping the whole time. Then you go from there. We do the ultrasound after that to look at your lymph nodes so that we can also stage you at the same time. Because if these nodules are just isolated on their own, a lot of them are just going to come out. We'll send you to the surgeon and they can take it out, and you just get scans to follow up. But going on with your question, it's really, you go in, they put you to sleep, we do the procedure, 30 to 45 minutes long, barring any complications. Then you go into recovery. You're spending maybe 2-3 hours in the hospital, then you go home.
So it's an outpatient, a whole outpatient procedure, really.
Yes, ma'am. It's outpatient, but it has to be done in the hospital, because of where we're doing the procedure into the lung. So, yeah.
So, and you said you're with Valley Health Systems, and I know they have multiple hospitals here. Is it only one of the hospitals that has this equipment, or do all of them?
So the robot itself is only at Valley Hospital. Summerlin has, as do we, have the technology that we used before the robot, and then the ultrasound diagnosis, the EBUS is what it's called. The endobronchial ultrasound is available between Centennial, Summerlin, and here at Valley.
Okay. So really, you just need to make an appointment at Valley Health Systems, having it been warranted through your screening and your doctor, etc. Correct?
Absolutely. Well, you need the referral to Pulmonary Associates or one of our groups that we can go and see the patient, and we refer everyone over here at Valley because we have all the equipment. The team is phenomenal. And so we've done these for so long that, everybody kind of knows what they're doing now.
So I actually want to go back one step because, even me working for the American Lung Association, I'm notorious for not getting screened. Mm-hmm. It is what it is. I'm like every other American. I don't know if it's laziness or fear, or maybe a mixture of both. But the screening process is pretty easy and painless, is it not?
Oh, absolutely. It's absolutely painless. As long as you meet the appropriate criteria, your insurance company will cover it. And the beauty of the CT scan that we do for the lung nodule screening is the radiation is much less. It's a low dose CT scan, allows you to get the screening and then move forward from there. Mm-hmm. So it's, you're not exposed as much as a lot of people worry about the radiation and all that, but it's much less than you would for a normal CT scan. There's no contrast involved. So, you're not going to affect any of your other organs. It's just basically you go under the CT scan, less than a minute, and then you come back.
Oh, really? And you get to lay down while you're being scanned, don't you?
Yeah, yes.
So if you're lazy, it's the perfect relaxing scenario, is what you're telling me.
Oh yeah, it's the best. It's all you have to do, and you're getting screened, so it's a win-win.
Now, oh yeah, really, exactly. So now, do you run the ion equipment? Is that in your purview?
What do you mean by that?
Like, are you the guy that steers?
Oh yeah. We're the ones that drive.
Now I know they're track boss. Yeah.
Yeah. So basically, we drive to the nodule or whatever the target is. We go down there, and then the only other thing we have to do from there is once we take biopsies, we have to take out the camera and things like that so that we can put our biopsy tools in. So
wow. Okay.
It's amazing. It is amazing.
And how many doctors like you are able to do these procedures? Or are you the only one?
Oh, no. That's a good question too. So there's other places that have other systems. HCA has one in one of their hospitals, and UMC as well. There's probably in the city, I would say, probably 4 or 5 of us.
So
that can do the procedure.
Are you the only one at Valley that does it?
That is correct.
Oh wow! Okay,
yeah.
So, and what kind of training was involved with that for you? Like, did you have to go back to school, or?
Oh, you have to take a course. You have to take a training course. Absolutely. You don't have to go back to school for like a year for it, but you have to take a training course. Then you have to have it proctored. You have to go to proctored cases. So we have to travel. Like I had to travel down to San Diego, which is, you know, who doesn't want to go to San Diego, right?
Sorry. Yeah.
Yeah. So I had to travel down to San Diego, take the training course. Then you have to go see a couple of cases. And then when you do your first couple of cases here, if you wanted to get trained in it, then you have to have a proctor come that is approved by the ION itself, so that they come teach you and do all your other things. The learning curve is pretty fast. Yeah. We have had experience with other equipment that we were using before to get to these peripheral nodules, but this technology is far better than what we had before.
So you really like this technology. You feel it's probably a step in the right direction then.
Oh, it's a game changer, I think. I mean, you know, the goal, like I said in the beginning, is to make sure we can get these people diagnosed earlier, you know, so people can have their loved ones and everything for a while. They don't have to go through chemo and radiation, because what we've been doing the last maybe, I don't know, 7 years before this, 6-7 years here, is we're getting to the lesions too late. And you know, these people have to then go through chemo and radiation, and if we can get to these people a little bit sooner, a lot sooner, we significantly increase survivability. And with the prevalence of lung cancer, that's make a difference to so many people.
Right. Okay, now I'm gonna admit it, this might be a dumb question, so just bear with me. Oh, I know, that's what they say. However, so one of my friends, she's actually our lung force hero this year. She actually was just diagnosed with, well, not just, last year was diagnosed with lung cancer. She actually, it was early stages, had it removed, but it was high up on her lung. It was in the top. So, you know, I'm envisioning this machine that goes, you know, in the throat, correct? Does it go in, down? So it can then come back up to the higher lobes of the lung?
Oh my goodness. If you could see where it went, it's amazing. Everywhere. Because the actual channel itself and the camera itself is much smaller than what we use conventionally. So it can go all the way out to the periphery, my friend. It's amazing. Yeah, so, it makes all those turns, everything.
And then, so then you locate the lesion or the mass, whatever we're calling it, lesion. Okay. And then you immediately take the biopsy at that point. Is that true? Okay.
So, you know, there's a lot of also confirmation tests or confirmation that we help to make sure that we're in the right location. We don't solely rely on the robot. We have the like the x-rays in there. We have an ultrasound that we can also stick to make sure that we're in the proper location. Because, you know, sometimes you still have to adjust. The robot's not 100%, but it's still phenomenally accurate.
Right.
So we do those. And then once we are pretty 100% sure in the target, then we'll do the biopsies from there, but that's correct.
Okay, so this is probably, I don't know if this is a dumb question, because you said sometimes people do have multiple nodes, like more than one, correct?
Correct.
Will you do them all then at that point, or will you just pick one?
That's a good question too. So it depends on where the first target is. So let's say your target is in the right lung, the top of the right lung up here, like you had said previously. What we do in order to stage the patient is we move to the farthest lymph node away and then work our way towards. Okay. So if the farthest lymph node is positive, then we don't do the rest. We'll just stay here because this will automatically stage, you know, up to a 3 from a 1. So if you're a stage 1 here, but your lymph node's on the other side, that moves you all the way up to stage 3. So we try to go from there and then move forward, move back towards the original. That's how we do it.
I love it. And I'm now.
Those are good questions.
Oh, this might be another dumb question, but this is how I learn, and this is my process, right? So let's say somebody is screened, there's lesions, nodes, whatever we're going to call them. You go in, you biopsy, they come back clean, right?
Mhm.
No, but because there's lesions, more than likely, would a doctor recommend to get screened again in like another 2 years, like to stay on
That,
top of it?
so that's a very good. That's actually very important. It happens all the time.
Okay.
All the time where we believe something is going to be cancer, comes out, there's no diagnosis. So there's a lot of routes that you can take from there. That's actually a really good question. So to clarify real quick, the lymph nodes are along your chest, right? They're along your chest wall. Lymph nodes are there to kind of designed to drain anything bad in your lungs. I mean, in your body in general, but specifically,
Right.
we'll talk about the lungs. So, you know, whether it's infection, inflammation, or it's cancer, that's how they get enlarged. And then the nodules are peripherally in the actual lung themselves. But so you're asking me basically, let's say we do this procedure and there's no diagnosis.
Okay.
And you're thinking, what's the suspicion? What do we do go from here? So depending on what your suspicion is for this, then you have to move forward with that. So let's say you have a spot on your lung. The
Okay.
patient's very high risk. They're a smoker. You know, let's say you didn't get it. There's either you rebiopsy. If they didn't get a PET scan, I would get a PET scan. And the PET scan basically allows us to kind of see if this is a more inflammation versus cancer. It's not definitive, obviously, but it helps guide you in making your decision if something like this happened. Or the alternative too is if the lymph nodes are negative and you have a spot on your lung here and you're high risk, you know, the nodules fairly decent size, like a couple centimeters, then you can just go to a surgeon and take it out. So there's multiple paths, and it's, you know, very patient dependent.
Yeah.
Whether you do it, you know, for someone that's high risk, or if they're not a smoker and they have this lesion, maybe you just want to get a repeat scan. The repeat scan earliest I would normally get is like just 3 months, depending on the size, of course. But mostly I get them scanning right away, 3 months. I, you know, talk to the patient, make sure we're on the same page, kind of go from there. There's other modalities to biopsy these nodules, of course. That's another option.
Sure.
So, but if I believe the patient is high risk and I am not happy with the diagnosis, I would convince the patient, you know, I tell them, listen, if you were like my mom or my dad or my brother or my sister, and this is what happened, this is what I would do. So
Right.
I could, you know, tell them what I think is the best plan of action from there.
Right. Wow. So it's so, you know, it's I could see how it's overwhelming to a patient, right? So take
Oh
a
yeah,
deep breath, right? Take a
yeah,
deep breath, have a good doctor, and
yeah,
then just follow up. Because it's so like it's so much better. My friend, the our lung force hero this year, she did have the surgery right away, had the tumor removed, and she did not have to have chemo or radiation. It was that
yeah.
early. How nice is that, right? Wouldn't
That's the goal.
that is the goal
Yeah.
for sure. That's way better. Okay, so now let me ask you. I'm going to ask you some personal questions, young man,
Sure.
but they're only doctor related. So
Okay, thank goodness.
you're yeah. The rest will come later. But so pulmonary, you're a pulmonary doctor.
Correct.
Yes. What made you focus on that? What was the thought process for you?
So initially, when I went into residency, I thought I was going to be a heart doctor, to be honest with you. And then I did, you know, the rotations that we have to do, and I really fell in love with the ICU actually also. So I do pulmonary critical care. So the ICU is where it started, and then, you know, from the subspecialties, pulmonary was the one that was the closest, I thought, to what would everything was going on in the unit. So I chose pulmonary from there, and yeah, I wouldn't go back to change it. I'll tell you that.
Right.
It's
So
been awesome.
you're in it to win it. And
Yeah.
earlier, before we started this whole conversation, you actually told me you were a local. You are a Las Vegas local,
Yes.
correct?
Correct.
And you went to UCLA, which is that's my choice of schools. Let me tell you, I'm a UCLA fan. I'm from LA. I did not go to UCLA, so I'm impressed. And I'm glad you
Uh,
didn't say USC because I'd have to stop talking to you. I'd be
oh
dying.
man, we are so much better now. You have no idea. I'd do this again for sure.
Yay! Actually, you know, it's so funny you should say that. because we did talk about, I think one of the things, and even for me, right, and this is what I do for a living, and even probably for you, um, there's always new medical advances. Almost every day, something new happens. May not happen in the pulmonary realm, but so, I definitely want us to be able to talk again about other things that are happening. So, for instance, um, again, it's not lung cancer, but if you're a pulmonary doctor, you also focus on COPD and other breathing disorders?
Oh, absolutely. We cover COPD, pulmonary fibrosis, sarcoid, all anything asthma, anything pulmonary related. We cover, especially in clinic. I see all those types of patients.
Yeah.
There's a few of us that have better focus on certain areas.
Yeah.
Like a lot of the nodules and everything will come more to me, but I still see the COPD patients and all that. And some of my partners will see like the pulmonary hypertension patients more or the sleep patients more. So yeah, but we still do cover all of that.
Right. So this is what I like. You guys share information with each other as well, do you not?
Oh, absolutely.
Yeah.
I'm never shy to ask somebody if they, hey, what do you think you would do about this? Because it's always better to have two minds on it than one. That's for sure.
Look at you. What a
Yeah.
rock star. That's because you went to Toro. That's why.
I appreciate you. Thank
Oh
you.
my gosh. So that's one of the things that I wanted to remind people of is, and actually you covered this as well, that sometimes things are very dependent on the patient, and the
Uh-huh.
patient does have to take advocacy for themselves, right?
Yeah.
They got to talk to their doctor. And it's interesting now with COVID, right? Are you finding more breathing issues that didn't even exist like 3 years ago? Or
Well, before COVID, the big thing, a lot of it was vaping. And so vaping kind of transitioned from there. Now it's COVID again. And we're
so it's
seeing a
always
lot of,
something.
yeah, there's always something out there that just gets you to a pulmonologist somehow. And
So
Vegas, especially with that weather changing all the
yeah,
time, it's the worst. And then you get people come in allergies, but then they think it's their COPD,
yeah,
and it's just one big vicious circle.
yeah. So it's not a bad idea if you're having problems breathing to go see a doctor. It
Yeah.
could be something easy and simple. Could be as simple as a little bit of medication, maybe, or it could be something major that you guys could catch early. So really,
Absolutely.
what you did cover the warning signs earlier, but it's not always the only thing that it's not always the only thing that could happen, right? I mean, you might not have any warning signs, which how do you then, how do you tell someone to go get checked? I mean, what's your thought on that?
That's a good question. So, depending on the situation, like if you're there for lung cancer, then we got to go through the screening guidelines at least.
Yeah.
But if you're not having any other real issues, as long as you get your checkup and you mention it, usually people get yearly chest X-rays also, things like that, just to stay up on their, general health. Because really, if you're not having breathing problems, you don't really need to get a pulmonary function test, nothing like that. It's not drastic enough, because a lot of those things are really they'll present once you have problems, but most people don't have problems and they don't need to actually see us if it's not terrible. So, just following up with your primary doctor is the most important for sure.
Okay. So actually, then that does give me the thought then, if you are having a breathing problem, it may not be a major breathing problem. It does not have to be lung cancer. But if you're
Correct.
having a breathing issue, it's okay to go find out what's going on, right?
Oh yeah, absolutely, absolutely. Never hesitate because you don't want it to get out of proportion to what you feel, and you don't want to say it was too late when you've been lingering with this cough or these, shortness of breath for so long that it gets to the point where it's irreparable. You want to at least make sure you get a heads up on it as fast as you can. Always
I
better
love it.
safe than sorry. Yep.
No kidding, right?
Absolutely.
Awesome. Okay, so now the ion machine, you have one at Valley for
Hmm.
you guys. So just I don't know if this is a legal question, and I'll edit it out if you want me to, but what's the wait time for a patient?
Oh, yeah. So once you get into the clinic, most of the scans, getting into the clinic is the most
How long does
difficult
that
part. Yeah, depending on the severity of all the situation, usually you can get into the clinic within a week or two.
Okay.
So, and then from there, the procedure itself, we can get you in within the first couple of weeks, depending on what the initial doctor that you see,
Mhm.
depends on the severity. You know what I'm saying? Like if they
Yeah.
think that the nodule needs to be done right away, they'll send it to a stat, and then we can get you moving from there.
Okay. So it's not a 9-month waiting time.
No. 9 months is too long. You
Okay, good.
already,
Just
yeah,
checking.
yeah. So, and a lot of the times, if you just give us a heads up, or the primary gives us a heads up, we can get them in sooner too. It depends.
Yeah. So no, that's actually honestly that was way quicker than I thought you were going to tell me. So I think that's awesome. I thought it
Yeah,
would be
especially
much.
for these. Yeah, well, certain diagnoses, sometimes it's a little, they get put a little bit farther back. It
Sure.
depends, right? But we will always, the boss kind of just screens and see which one's the most important, and they usually come in right away.
Yeah. So you're working full days. How many biopsies could you do in a day?
Oh, that's
Or
good.
let
Yes.
me rephrase that question. How many
Uh-huh.
of these procedures with the machine can you do in a day?
So with the robot, I would probably max out at 3, just
Okay.
for until we get a little bit more efficient with the system.
Yeah.
I would do 3 at the most in one day. We do
Okay.
other procedures, of course, but
Sure.
those 3, because they take time, and you don't want to get to the end of the day. And I mean, this is just me. You don't want to get to the end of the day and not give the same effort that you gave the first person.
Right.
So I want to make sure it stays consistent, and I got enough for sure for at least 3.
Oh,
Yeah.
actually, that's awesome. I think 3 is a good number. Right.
Yeah.
And you're right. I want you fresh and ready to go. And I also, your eyes get tired. You're looking at
Yeah.
very intricate. I actually have never seen the inside of a pair of lungs. I don't know that I ever want to. I'm
Yeah.
I'm a little weak when it comes to such things, but I
Better than the
appreciate.
stomach.
Yeah. Oh gosh, good to know. I do appreciate that you're willing to do it, though, young man. So, Dr. DelMundo, is there anything that I have not asked that you think people need to know about this equipment?
Uh, Not that we didn't cover already.
Okay.
It's just good equipment. It's really good technology. It should, like I said, be a game changer for the community. I mean, we're not the only ones that do it, but someone needs to get out there and make sure that people are aware that we can get these things and increase people's lives. I mean, the survivability of their lives. I mean, it's a big deal. So
That
I
is a
think,
big deal.
yeah,
Yeah.
it's much better to get it early than it is to get late, and I think that's the goal. So we should stick with that.
I love it, actually. And that's it's a great thing about this job as well is, I work hard to try and fund a cure for cancer. Although doctors correct me all the time, we're never going to cure cancer, but we can reduce its impact on people's lives by finding it early, by removing it, by shutting it down as best we can. And that's what I was like, all right, then that's what we'll focus on. I get it. And
Yeah,
I don't want any more friends to get or pass from cancer. I'm done with that, right? It's no fun. Don't like it. So I appreciate you being willing to share this information. And I love that we just equip people to know that there are alternatives out there for them, that they can go get screened. And it doesn't have to be it doesn't have to be a death sentence. Catch it early and let's get rid of it.
yeah, that's the goal. And like I said, I think that's the best way to put it. People, they hear cancer, and of course, natural reaction is to
Yeah.
kind of be overwhelmed, get depressed, think it's over. But and the technology, not just in pulmonary, but in a lot of other fields as well. But specifically for us, I mean, these are things that you can actually live past your cancer. Like you don't
Right.
have to, you're not even living with it anymore. You already survived it. So, you know, so I think that's a big deal. And to have these people know that there's still opportunity after that. It's not a death sentence. That's a real good quote. That's very good.
Yeah. Awesomeness.
Yeah.
Look at us. Oh, Dr. DelMundo, thank you so much for joining us for this episode. You will obviously be hoodwinked into doing a few more episodes with us. Just any opportunity we have to learn and talk to our constituent base about the options that are out there are really good. And you know what? Again, it's just reminding people that let's catch it early. Love it. Thank you so much for joining us.
Oh, thank you for having me, man. It's a pleasure. It's an honor. You guys are good people. Anything we can do to help support you all too, we appreciate it. All that you guys do. Thank you so much.